Hello everyone, this video is about bundle branch block. So I'll be talking about both right and left bundle branch block and also their ECG findings. So let's get started. Before really moving on to the bundle branch block, let's briefly discuss how the electrical signals flow through the heart. Electrical signals are generated in as a node or sinoatrial node present in the right atrium. These signals from SA node propagates to both left and right atrium and causes them to contract. Then the signals move to AV node or atrioventricular node. Through the AV node, it reaches to bundle of His and this splits into right bundle branch and left bundle branch in the ventricular septum. The signals then move to both ventricles through Purkinje fibers. This leads to contraction of both ventricles. Now, a bundle branch block is described when electrical signals are completely blocked from passing through one of these bundle branches. If signals cannot pass through left bundle branch, it's called left bundle branch block, and if it cannot pass through right bundle branch, it's called right bundle branch block. Now, usually a bundle branch block occurs when a fibrosis develops in one of the bundle branch. Fibrosis may be caused due to some acute causes like ischemia, heart attack, or myocarditis, that is, inflammation of heart muscles, or due to other chronic heart diseases like hypertension, coronary artery disease, and cardiomyopathies. Now, if we look into this picture, the right bundle branch is affected, so this is right bundle branch block. In this case, the signal is generated from SA node. This contracts both atrium, then it moves to AV node and then to bundle of His, and from bundle of His the signal moves to only left bundle branch because right bundle branch is blocked. So from left bundle branch the signals flow to the Purkinje fibers on the left side of the heart, and from the left ventricle the signals will then flow to the right ventricle. So since the signals first reached to left ventricles, it will contract prior to right ventricle in case of right bundle branch block. And the same is gonna happen in left bundle branch block, but this time right ventricle contracts first followed by left ventricle. Now, if we look into a normal ECG, we'll find a characteristic P wave which represents atrial depolarization that corresponds to atrial contraction. Then we have QRS complex that represents ventricular depolarization, which corresponds to both ventricular contraction. Normally, it takes around 80 to 100 milliseconds for ventricular depolarization. But if there is a bundle branch block, this time can increase up to more than 120 milliseconds. Because in a bundle branch block, the depolarization, although it starts in time, it takes longer for the signals to reach one of the ventricle. Hence, the depolarization time will increase. This means the QRS complex will get widened. So this ECG finding we just discussed is from lead 2, which is a limb lead that's connected to right arm and left leg. While we still can get tons of information from this lead reading, it's often helpful to use other leads as well, like chest leads. These leads can help us to differentiate right and left bundle branch block. Let's see how. While the limb leads look at the heart from a plane that's perpendicular to the ground, the chest leads are arranged so that their plane is parallel to the ground. Hence, we can look at the heart from a completely different perspective through chest leads. We know there are 6 chest leads from V1 to V6 arranged in the body as shown in the picture. But we are going to look at leads V1 and V6 only because these leads are the farthest apart from each other and therefore have most contrast between views, which means through these leads we can look at the heart from different perspectives. As the electrical signals are moving through the bundle branch, they depolarize the septum. The wave of depolarization moves from septum towards the right ventricle because of larger muscle mass of ventricular septum. So the electrical waves are moving towards lead V1 and away from lead V6, which means you'll get a positive deflection in V1 and negative deflection in V6. Now, as the signals move from the septum to the ventricular walls, since left ventricle has way more muscle mass, a large portion of electrical waves will be directed towards lead V6 and away from lead V1. So you will get negative deflection on V1 and positive deflection on V6. So this is the normal. Now let's say there is a block on the left bundle branch. So since the left bundle branch cannot conduct electrical signals, the wave will come from the right side of the heart, that is towards lead V6 and away from lead V1. So you will get negative deflection on lead V1 and positive deflection in V6. V6 will also often be notched from left ventricular depolarizing late. V1 usually has QS complex with absent R wave or a RS complex with small R wave, either of which giving it a W shape. Notch in the lead V6 gives it a M shape. Now, if there is right bundle branch block, the initial part is similar to normal. That is, the waves will move from left side to right side. So positive deflection on lead V1 and negative on lead V6. As the signals reach to left ventricle from left bundle branch, the waves will be directed towards lead V6. So positive deflection on lead V6 and negative on lead V1. Again, in the late stage, these signals will now move towards the right ventricle. So positive on V1 and negative deflection on V6. So lead V1 ends with a large terminal R wave. So the terminal R wave will be larger in lead V1, giving it an M shape. In lead V6, there will be a slurred S wave, giving it a W shape. Now, if we bring these together, there is a W shape in lead V1 and M shape in lead V6 in case of left bundle branch block, and M shape in lead V1 and W shape in lead V6 in case of right bundle branch block. And this sets us up from an awesome mnemonic, that is William Marrow. Some people with bundle branch blocks are born with this condition and are usually asymptomatic, so they do not require any treatment. Some severe cases may need cardiac resynchronization therapy. This is a type of pacemaker therapy that helps the ventricles contract at the same time. Cardiac resynchronization therapy can increase the amount of blood that the heart ejects and can improve symptoms of shortness of breath and fatigue. So that's it for today. Thank you.